with the heart failure with improved ejection fraction. And I think this is very important for our therapeutical side on the patient. It's another thing whether the patient has been on ejection fraction below 30% and then improved with medication, or if he has been only with 45% as its worst ejection fraction. So in the first time, I would not stop any medication, and the other, I will not need to have things like mineralocorticoid receptor antagonists. So what is about therapy? First of all, do the underlying disease, do revascularization, do edge-to-edge repair or TAVI in severe aortic stenosis, in ablation, in atrial fibrillation, do ablation therapy, do devices, do cardiac resonoration therapy, go to LV assist devices or go to heart transplantation. You have to think of all these for your patients. Let's go back one step to think about heart failure. Heart failure means there is a reduced stroke volume, and this will activate structural, neurohumoral, cellular, molecular mechanisms that will lead to volume overload, sympathetic activity, cardiac remodeling, inflammation. That again will worsen the cardiac function, and there will be more reduction of stroke volume. This is a vicious cycle in heart failure, and the spiral will go downward. And you can help with your medication. And you all know this analogy with the donkey. The donkey, this is the sick heart, and the donkey has to work very hard with this. And pharmacological therapy in heart failure means to unload the car with the things so that the donkey can do better, or to limit the speed. This is by beta blockers, and maybe you can give the heart for some moments another goal to do. So let's look at all the medications and the drug therapy we have in chronic heart failure. And it's since 35 years when the first trials were published on ACE inhibitors. They were against placebo, and you so see that with ACE inhibitors, the patients do well. And then there were the beta blockers, and then the mineralocorticoid antagonists, and then you see here the ARNI, and you see the ivabradine. You can see all this medication, and again, the medication will be better than placebo. And that's very important. From this work I've just showed you, they did a forest plot for all these medications. And you see here, when you add another medication, then the patients will do better. And that is not only for their capabilities, but this is mortality. So they will live longer with this for adding more medications. So we are eager for looking for new medications. Let's have a look at the actual guidelines. They are from 2060. This is the ESC guideline, and this is the American guidelines, and they do not differ. They are only different schemes to follow, but they all show that ACE inhibitors and beta blockers, MR antagonists, and then the ARNI or the ivabradine goes, and then you have to consider other things. So the basis is the same. But when you see all these things, then you have to think how many patients you have to deal with this medication so that mortality will be reduced. And for the ACE inhibitors, it's 26, it's 9 for the beta blockers, it's only 6 for the mineralocorticoid receptor antagonists. And you have to look for the side effects. Every doctor, every physician who is dealing with heart failure patients should know these side effects and when to change medications. And he should know the initial daily doses and the target daily dose. I think this is very important, for often the patients will start with a low dose of heart failure therapy and the target dose will never be reached. This is the second table for the ivabradine and for the ARNI and for the sodium glucose transporter inhibitor. So you see, you have to see for these number needed to treat for mortality and for the side effects on for the daily dose you have to reach. Why is this though important? This is not old numbers, but this is from 2019, and this is the survival for heart failure for 5 years and for 10 years, and it is not very much better than 20 years ago. Also, we have so good medication in the last years. And I think this is because many patients will not get the target doses. This is data from an American Congress now in May this year. And these are patients with variable cardioverter defibrillator at the index time and then 19 days later. And you see here for the beta blocker that at the beginning only 15% have the target dose, and 3 months later it's only 25%. And it's the same for the ACE inhibitors or the RNBs or the ARNIs. There are only few patients that will get the target dose. And I think this is a problem. And Milton Packer addressed this problem in a work in 2020, and he says that there is only a very small fraction of patients, that is below 1%, and I could not mention this number, below 1% for the heart failure patients that will receive all the life-prolonging treatments in the trial-proven doses. I think this is a very small number, and he says there are 3 stages. The one where the patient receives the target dose that is consistent with the trials, and then the status 3 that he will not receive a specific treatment. And I think the most important is the status 2, where the patient receives a medication, but not in the target dose. And he says this is because they have never been prescribed a higher dose, or they had asymptomatic changes in heart rate or blood pressure, so that the physician or the patient preferred not to give higher doses. And this is the same for the beta blocker or for the spironolactone or for the ARNI or for the ACE inhibitors. There are often asymptomatic changes in blood pressures. And I see this in daily life. The patient comes and says, I had a blood pressure of about 110 to 70, and so I will not take a higher dose. I don't want to do this, and my physician at home tells me the same. But what does this mean for the patient? You know, you see here dose-dependent survival rates for the beta blocker and the different doses. You see here that the survival is best with beta blocker in high doses, but it's less favorable for the medium dose or the low dose, even if they are better than no beta blocker at all. But this means something to the patient. And I show you this slide with some calculations about survival. And you see here, there is the survival after 45 years, a patient, and he gets the ACE inhibitor and the beta blocker. He has no mineralocorticoid receptor antagonists. It's the data from the EMPhASIS HF placebo group. And then you can see here the group with the ARNI instead of the ACE inhibitor, the beta blocker, the mineralocorticoid receptor antagonist, and the SGLT2 inhibitor. And what means this for the patient? There is a difference between these both lines of 6.2 to 10.7 years. And I think this is a long time for a patient, and this is only for giving the guideline recommended therapy. Let's talk about the ARNI. It was on the last slide. We can switch from an ACE inhibitor or Satan to an ARNI, and what we have to know is that we need to discontinuate the ACE inhibitor for at least 36 hours before we use the first dose of ARNI. This is because of the bradykinin. For if you give them simultaneous, there will be an accumulation of bradykinin and thus can provoke angioedema. If you have Satan, you can swap directly. I think in the new guidelines, in the upcoming guidelines, we will be allowed to start with an ARNI in some patient groups. We in Göttingen begin with an ARNI in young and severely heart failure patients with ejection fraction of below 20%. We will not take the ACE inhibitor, but we will start with the ARNI to give the patients the better medication right from the beginning. I like this table very much. You see here all the studies from the last 35 years, and you see here the studies that were done since the last guidelines were published. And I think the best to know is the sodium-dependent glucose transporter 2 inhibitor. It worked in the kidney, and there will be the glucose reabsorption in the kidney, and this will go together with sodium, so that sodium and glucose will go with the urine, and this means that the patient will lose the water and the sodium and the glucose, and this will help him to have a better outcome also with his diabetes, but again with his heart failure. And there are two great studies that were done with these drugs. The one is the EMPEROR reduced with the empagliflozin, and the other is the DAPA-HF with the dapagliflozin. There were patients with an ejection fraction below 40%, but with not so bad kidney function. The kidney was not normal, but it was not so bad. And you can see here that the primary outcome, this is the DAPA-HF trial, the primary outcome was significantly reduced in the dapagliflozin group, and the primary outcome is a combined endpoint from hospitalization and from death. You see that for hospitalization, it is significant. It's not significant for death from cardiovascular cause or from death from any cause. But the outcome is good, and you can prevent rehospitalizations for heart failure patients. And you see here all the subgroups, and the best to know is that the dapagliflozin works either in the type 2 diabetes patients and also in those who had no diabetes. And it was the same for the kidney function. The drug is working with preserved kidney function and also when the kidney function is lower. There is another study with dapagliflozin in chronic kidney disease, and you can see here that the dapagliflozin patients do better than the placebo patients in worsening the cardiac function, though it's not only good for the heart, but it's also good for the kidneys. The same is with the other substance with empagliflozin. The EMPEROR-Reduce trial could also show that the primary outcome, which was hospitalization for heart failure and death, was significantly reduced, but it was also not significant for death. But hospitalization is significantly reduced, and I think this is very important for our patients. What is about the side effects of the SGLT2 inhibitors? There is a volume depletion, and so for daily practice, we have to look for our diuretics, and in some patients you have to reduce the amount of diuretic medication so that they will not have a volume depletion. There may be a diabetic acidosis in this patient. It's not very often, but it may happen, so that you have to be aware of this. And there are many infections from the urogenital system, so you have to talk with the patient about this. There is glucose in the urine, and this may promote these problems. So these are substances that you can give to every patient with heart failure when the renal function is not below 30 milligrams per liter. So what did our ESC guidelines on diabetes do with these data? They have two groups of patients, the one that have no medication for the diabetes and the others that are on metformin. And if there is a cardiovascular risk, atherosclerotic disease, then you will start with an SGLT2 inhibitor or GLP-1 therapy. So the cardiologist of today has to deal with diabetes, and he has to look at all these things, and we do not think about the glucose level at our first goal, but we have to think of the mortality of the patients and their risk for cardiovascular disease. I'm near Hanover, so we are waiting for the DIGIT-HF study. Hanover Medical School works on the digitoxin for heart failure. It's an old drug. The old guidelines deal with the digoxin, and the digoxin has, I think, rather worse done in the last years. So we have to think that this drug goes out of the body via the kidneys, and so that in our sick patients, the levels will increase, and this is not good. For the nowadays, target levels are lower, and when you deal with digitalis, then please take the digoxin. And I think it will be very important to see the results of this study. I think they will come in 2 years. And there are two novel treatment approaches. The one is the vericiguat. You know this class of substances from the riociguat. You know that you can treat with this substance in those with chronic thromboembolic pulmonary embolism. This is another of this group. It's a stimulator for the soluble guanylate cyclase. And the other is a myosin activator. The myosin activator, omecaptiv mecarbil, was tested in the GALACTIC heart failure study. Let's go first to the Victoria study with the vericiguat. It was given in heart failure patients with reduced ejection fraction. And you can see here that they were significant for the primary outcome. This means no heart failure hospitalization, but it was not significant for death. So you can help the patients with recent cardiac failure to stay stable with this substance, but there are no data that you will decrease mortality. The myosin activator helps the myosin to bind to the troponin. You see that before you give the substance, only few of the arms of the myosin go to the troponin, but with the substance there will be more, so that the myosin is activated. And the substance is oral, given 2 times a day, and it was tested in the GALACTIC HF trial and published this year in January. And it's the same. There was patients with reduced heart failure, with reduced ejection fraction, and they had recent heart failure episodes. And you see here that it's significant for the combined outcome, which means heart failure hospitalization and death, but it's not significant for the death alone. So you can give these substances for patients who are very unstable, but you will not do anything for mortality according to this data. So let's look at our patient. The heart failure patient has more problems than only the heart. He has comorbidities. Most of them have more than 8 comorbidities. Maybe his weight loss, he falls, he has physiological problems, dementia or depression. He has functional problems in daily life, and he has social problems. Sometimes he lives alone, or he has no social support. So think of all these things. I think the most important is the iron, where we have the new data. So let me summarize my talk with this slide. For this was published this year in the European Heart Journal and shows the Fantastic Four. The German will know that Fantastic Four, that is a band with music, but I think we have now the Fantastic Four also in cardiology for our heart failure patients. The beta blocker will stay on the stage. The MR antagonist will stay. The ARNI will be the beta. but ACE inhibitors or RIB are of value if the cost concerns. The SGLT2 inhibitors have shown that they are very valuable for our patients. And I think with all this fantastic fall, you have to deal with the other things around. I started with the slide where I showed you, you have to look for other problems like the valvular things, or and you find it here with the mitral edge-to-edge repair, or the CRT for the pulmonary vein isolation, the iron in ferric carboxymaltose. And I think this is a very good summary for what you have to look at before you refer a patient to LVAD implantation or transplantation. So the new guidelines will come soon. They will, I think, arrive in August on the SC Congress. For the program of the Heart Failure Congress in June, I did not find the new guidelines. And so I want to stop and thank you for your attention, and thank you for your giving a second chance for me. And now I think we will open for discussion.